Okay, great. Good morning, everybody. Thank you for joining us this morning for the session Positive Childhood Experiences Before and During COVID-19 in the Service Provision Challenges track of today's conference. We're looking forward to a great session. A few logistical notes as we begin. This session is being recorded and the chat is also being archived. All attendees are in view-only mode to keep things orderly, so you cannot use your microphone. If you do have a question for the presenters, a technical issue, or anything else that you need some clarity on, please use the chat box, which we'll monitor throughout the session. You can also message me directly, content moderator Megan, and we'll try to work through these as we get any issues in. We'll save questions for Q&A at the end of the session. Our session is set up to use auto captioning today. We're having a little bit of trouble with that feature right now. So once we get started, I'm going to get under the hood and try to get that working. Apologies if we do not get it working in time. You'll also see that we're joined today by ASL interpreters who will appear using gallery view. This should be standard on everyone's screen at this point. If you're intending to claim professional development credit for this session through the South Carolina Endeavor System for Early Childhood Educators, please complete the submission form that I'm going to share in the chat box in just a moment. You will need to submit this form for every session that you attend today if you're using the Endeavor system. I've heard from several folks that they do not have their student ID registry number handy. If that's the case, just put NA or don't know in that box and we'll try to make it work on the back end. The event will also offer clinicians credit, and we'll share more information with that in our post-conference follow-up email. All that housekeeping out of the way, I am delighted to attend our speakers, introduce our speakers for today's session. Dr. Elizabeth Crouch, PhD, Deputy Director of the Rural and Minority Health Research Center and Assistant Professor in the Department of Health Services Policy and Management at the University of South Carolina, and Jan Probst, PhD, Distinguished Professor Emerita and Director Emerita for Rural and Minority Health Research Center at the Arnold School of Public Health at the University of South Carolina. They'll give you a little bit more context on themselves and their roles. Looking forward to a great session, and at this point, take it away.
Okay, this is Jan. Dr. Crouch and I are going to tag team this whole entire event. And if you could flip to the next slide. There we go. I'm going to tell you who we are, and then since you all had a chance to look at the title slide, tell you why we're going to talk about things. Dr. Crouch and I are both with the Rural and Minority Health Research Center at the University of South Carolina, and I won't bother reading the mission since you can probably figure out what it is simply by, well, that went a little fast, there we go, simply by looking. But one of the things we really do is kind of drill down more than other people do to look not just at rural health, which a number of organizations do, but look at minority health within rural health. And as you can see, we are a fairly diverse and unusual group ourselves. Next slide. When we look at health disparity populations, there are a number of them that can be studied and that are officially designated by the National Institutes of Health, running up from the bottom: geographic region, nativity, disability, sex and gender minorities, persons who are poor. All of these populations have distinct issues. Our focus within all of these possible problems, like I say, is rural health, which I think has really come to a head with COVID and the fact that COVID rates are higher in rural counties across the country than in urban counties, and of course, racial and ethnic minorities within rural populations. Next slide, please. So we're going to talk about two things today, and they have sort of matching, what do you call those things?
Acronyms.
Thank you. That's why there's two of us. The first is, as you saw in our header, we talked about positive childhood experiences, and we're going to talk about that. But before we get there, we're going to talk about why we need positive childhood experiences, and why we need positive childhood experiences is to, if you will, balance out adverse child experiences. So we got that. There's our setting. We're going to talk about positive. We're going to talk about adverse. And because adverse is what we want to cure with the positive, we're going to talk about it first. We're going to talk about what the adverse childhood experiences are and why precisely we care about them. Next slide, please. Okay. Adverse childhood experiences, as you can imagine, are bad things that happen during a kid's life. things that cause lasting trauma. And we'll, in a subsequent slide, we'll talk about what these mean. These include actual abuse, physical, sexual, or emotional, neglect, and household dysfunction. And all of these, if you will, bad things are A, more prevalent than people probably realize, and B, associated with negative, adverse health things, even in adulthood. So it's not just, oh dear, little Johnny is upset. It's, oh dear, this may be with little Johnny through the rest of his life. Next slide. This whole concept of adverse childhood experiences was first identified by these two gentlemen, Dr. Robert Anda and Dr. Vincent Felitti, who did a study of Kaiser Permanente enrollees. Kaiser Permanente, for those who may not know this, because it's a huge health maintenance organization in California. It's been in existence since basically the 1940s. They have enormous data sets and enormous numbers, but of persons who are covered in the state of California. And when they began their study, they were able to look at over 17,000, this is a large number, of adults. And what they did is asked adults about things that had happened to them in early life. So these, when we're talking about adverse childhood experiences, these are adults remembering things that happened to them when they were children. And what's so unique about this study is its huge size, and the fact that they were very systematically able to identify things that happened later. And I will also point out, for people here in South Carolina, this population that they studied in California was a relatively privileged population. Most of the persons who were insured through this fancy-dancy Kaiser Permanente system had attended college. Only 6% didn't have a high school diploma, as opposed to a much larger percentage here in South Carolina. And they're basically white middle-class people with access to some of the best healthcare in the world. Next slide, please. There we go. What they found, and this is sort of grim, but I will nonetheless try to read it to you, is that household dysfunction was really, really common. They found that substance abuse, about that 27% of adults remembered that one or more parents or other adults in their household abused either alcohol or drugs. 23% parental separation or divorce, 17% mental illness in the home, violence against a mother, 13%, criminal behavior. This is a lot. Then we get into neglect, emotional neglect, 15%, physical neglect, 10%, abuse, emotional abuse, different from neglect, 11%, 28% remembered physical abuse, and 21% remembered sexual abuse. This is a lot of bad things happening to kids. And one of the things that is interesting about this, by the way, is not only are these all individually bad things, but as sort of indicated by this slide, this number, the fact that they count them, there is a dose response effect. The more bad things that can happen to you in your life, the worse it is for what happens to you as an adult, how the behaviors you may have learned, how you implement and act through your adult life. Next slide, please. Oh, these are a little bit hard to read. They're much bigger in the big screen here, but just to go through them really quickly, you'll notice this is the range of things that have been demonstrated. And this little, if you download our slides later, this is all available at the CDC's website. You have injury, bad effects, that traumatic experiences in traumatic childhood experiences are associated with traumatic brain injury, fractures, and burns among adults. In the mental health realm, they are associated with depression, suicide, and anxiety. In the area of maternal health, unintended pregnancy, pregnancy complications, and fetal death. In terms of infectious disease, which also goes down to risky behaviors, they're associated with greater prevalence of HIV and sexually transmitted diseases. adverse childhood experiences have been associated with chronic disease, such as cancer and diabetes, from bad behaviors, such as alcohol and drug abuse and unsafe sex, and from the opportunities that you have. So this is a whole, as they've made it nicely in their diagram, a constellation of ill effects. Next slide, please. Like I say, and as I noted before, all of these are on a dose response. Having one bad thing in your life doesn't set you on a road for adult disaster. But if you have 4 or more, even on the research that Dr. Crouch and I have done, she's a leader on this. Trust me, she's a leader on this. They are more likely binge drinking, to smoke, even when you've got a condition such as COPD that is going to be exacerbated by smoking, and to have poor self-reported mental and physical health. So I've sort of demonstrated, I hope, that adverse childhood experiences are bad for you. So I'm going to turn it over to Dr. Crouch to take the more optimistic side and talk to us about positive childhood experiences.
Thank you so much, Dr. Probst. So Dr. Probst gave a great intro. If you want to go to the next slide, please. A great intro as to what are adverse childhood experiences. We acronym them as ACEs. So that original study by Felitti and Anda was from 1999. So now we've had over 20 years of research on adverse childhood experiences. Only recently, we've had many different ways of quantifying these positive childhood experiences in the past, but really the quantification and the theoretical framework surrounding positive childhood experiences is relatively recent. So I attended a conference out in Montana with Dr. Bob Sege from Tufts and Christine Bethel, who's at Johns Hopkins, and they were really leading the way talking about the beginning of positive childhood experiences. And they've gotten several grants and have been very prolific publishing on what these are. And this is kind of an emerging field in this on how do we mitigate and moderate ACEs. So next slide, please. Okay, so I'm going to give you examples of how we're quantifying these positive childhood experiences, but many of these you're probably already familiar with. So can you share ideas with your caregiver? Do you have a mentor? Do you have a safe, stable relationship? So we are going to quantify these at the individual level, but as this research has unfolded, we're also beginning to quantify these at the neighborhood and community level, because we know people live within place. We know place matters as well as just these individual relationships. So the great news is there are ways to mitigate, moderate, and prevent adverse childhood experiences. And that is where we bring in these PCEs. Next slide, please. Okay, so we know that adverse childhood experiences give kind of a fight or flight response, right? So when children are really have a negative experience happening to them, so there's substance misuse, for example, in the household, it may cause what's called toxic stress. So Jack Shonkoff originally started this work looking at the neurobiological part of this. So what happens? We have this fight or flight, we have all this cortisol that hits our brain, and we have what's called toxic stress. And so that is what Dr. Probst had mentioned that, has led to poor mental and physical health. Felitti and Anda's work focused on obesity. So we had more overweight, more obesity of people that experienced more ACEs. But the positive thing is we have these positive childhood experiences that we can implement at the population level, at the community level, and the individual level, which may prevent ACEs, reduce toxic stress, and promote healing. So next slide, please. All right, so I want to give a little bit about the theoretical framework in which have begun to measure what these are. So we know there's programs that may support this, and so how do we construct those? Sege and Bethel came up with this, what's called a HOPE framework. So it's healthy outcomes from positive experiences. And it's looking at, okay, how do we measure these strengths, these social networks, these connections in order to reduce, mitigate, moderate historical trauma, as well as structural racism. So one of the things that Dr. Probst gave an example of adverse childhood experiences that has been measured as far as individual physical and sexual neglect. There are also ways to measure these, which we'll go over in a second, where we talk about other ways that may be measured. So parental divorce, parental death, structural racism. So are you experiencing racial ethnic discrimination? These are all additional adverse childhood experiences we won't go fully into today, but I do want to make sure I mention them. Okay, so this HOPE framework. Next slide, please. So we're going to break this down real fast. The first thing to talk about is relationships. So what do we want to measure with relationships? We want to know that parents and caregivers are responsive to a child's needs, that children have family outside of the household that take a genuine interest in a child and support their growth and development, that children have healthy and close peer relationships, so not just with adults, but also with their peers. And so what we know is that individuals that have had these types of relationships often have much lower rates of depression, mental and physical, poor mental and physical health during adulthood. And when we talk about families that have kind of overcome or had some resilience, one of the main things they may mention is these positive relationships with other adults. Next slide, please. So there's 4 building blocks. The first one was relationships. Second one is environment. So what do we mean by a safe, equitable, and stable relationship? So it's a place, a home where a child can feel safe and secure. They have proper nutrition. They get enough sleep. They have a normal routine. Their environment gives them opportunities for high quality learning. It's a safe place where they can play and interact with other children. And this gets into some of these inequities we may face in environments, which we'll talk about again later on. Next slide, please. Third building block, engagement. What do we mean by that? So children need ample opportunities for productive social engagement. So do they feel involved in projects, peer mentoring, community service through one school or religious organization? Are they able to partake in families' cultural activities? This could also include organized music, art, sports activities. It's just ways for children to feel connected and loved and appreciated within their communities, which will help them become resilient adults. The next slide, please. The fourth building block is, again, we're developing this social and emotional and behavioral self-regulation. So are we giving children, are we helping them learn how to respond to challenges in a productive manner, right? So helping them develop self-awareness, learning how to self-regulate. A lot of this happens during child-centered play. I have a 4-year-old and 18-month-old, so I'm seeing it with my own kids now. How do they learn emotional regulation? As I'm sure you all know, the 18-month-old has almost none, and the 4-year-old is beginning to get some of these skills, right? So these become very important for children to become resilient and emotionally healthy adults. Next slide, please. So our group, Dr. Probst and myself and our friends at the Rural Minority Health Research Center have begun to publish on this, and one of my general interest in life is in rural health. And so we're going to get more into the rural aspects of this, but we have used the National Survey of Children's Health, which is a population-based survey. We go all 50 states. We get about 50, usually interviewing about 50 some odd thousand people, caregivers a year. We looked at multiple years of this, and through this survey, this population-based survey, we've been able to quantify what's happening rural versus urban and adverse childhood experiences, as well as what's happening in this new emerging field of positive childhood experiences. So this is just, again, one survey methodology where we can use to start to quantify some of these. Okay, next slide, please. So how do we measure some of these things? So nurturing supportive relationship. The survey asks for mentorship. Is there at least one adult who knows this child well, who they can go to for advice or guidance? Okay, that's one way to measure it. Another way we've measured it is family resilience. So when your family faces problems, how often do you talk about what to do? Do you work together? Do you know you have strengths to draw on? And do you stay hopeful in difficult situations or difficult times? So these are 2 questions of how we may measure that nurturing supportive relationships within the HOPE framework. Next slide, please. The next building block, as y'all recall, was that safe, stable, and protective and equitable environment. And this is where we're getting to some of those neighborhood offerings. So the neighborhood. So does your neighborhood help each other out? Do they watch out for each other's children in the neighborhood? When you encounter difficulties, do you know where to go within your community? And if they ask about a multiple statements, where is the child safe in the neighborhood? So can the child walk around, the child be in the front yard, etc. Next slide, please. All right, how do we measure constructive social engagements? This is the third building block of HOPE. After school participation. So this is for kids 6 and above. So kids 6 to 17 and how they measure this. Did the child participate in a sports team? Were there clubs or organizations? Were there activities or lessons? And I want to pause here for a second because some of this talks about what's actually offered, which again, this is a kind of a social construct, right? We talk about this. I don't want to make it seem like caregivers or children are choosing these things. They may just not be available in their areas. So volunteerism. During the past 12 months, did the child participate in any type of community service or volunteer work, whether it be at school, church, or in the community? And then our next slide asks our final building block, that social and emotional competency. So how well can you share ideas, talk with your child about what really matters in life? Okay, next slide, please. So our first paper, kind of one of our first pubs beyond the rural-urban differences in PCEs, this is a paper we just got accepted in child abuse and neglect. And one of the things is looking at, okay, what's the overall prevalence of this? Among ages kids 6 through 17 at the population level, which of these PCEs are being offered? And then, again, this data is from, we're using for this paper, for this example, is from 2017 to 2018. So pre-COVID, what's happening pre-COVID at the population level for kids? And then we also want to know, does this differ by racial and ethnic minorities? And I do want to give a quick preface as to why that matters. In our country, we have structural racism, and we have the social construct of race, where it's become, we have redlining, we have different community offers based on race, et cetera. So we want to look and see what's happening among minority groups. Are they being offered these at the same rates? Okay, so overall, 80% of kids having 6 and above are having after school activities. A little bit less than half, so 44% are volunteering in a community. Almost 90% have someone they can go to for advice, which is wonderful. 2/3 live in, share ideas with a caregiver or live in a safe neighborhood. Over half live in a supportive neighborhood. And then over 80% of children's, and it's the caregiver responding, but we talk about it in terms of the child, because it's population based in terms of the kid, as 81% have family resilience. And then, as Dr. Probst mentioned, we have the scoring mechanisms. We have ACEs, or we know that 4 or more, you lead to worse outcomes. PCEs are just kind of looking at the score mechanism. So 90% of our sample had 3 or more. And what we're seeing is, I'm just going to give a quick overview, is we're often seeing the white children, non-Hispanic white children, having higher rates of majority of these ACEs compared to their African Americans, non-Hispanic, Black, and Hispanic counterparts. And the ones that were significant for that were after school, volunteer, mentoring, family resilience, all the ones in bold. So we are seeing racial ethnic differences in this, which means we need to figure out new ways, which we'll get into in the talk, new policies and programs to make sure everyone has a seat at the table for this. Next slide, please. So let's start looking at, we looked at adverse childhood experiences, a number of outcomes into adulthood and within kids. Let's talk about what's happening. So PCEs, kids that have experienced PCEs or are experiencing PCEs, what's the relationship to school success? Next slide, please. This is a paper that's under review at Maternal and Child Health Journal. So what we've seen is that children who repeat a grade in school were less likely to have all of these positive childhood experiences except for neighborhood safety. So there was a statistically significant relationship between repeating a grade and all these positive experiences minus neighborhood safety. So many of these experiences implemented could help children with some academic success outcomes. Next slide, please. We also looked at school absenteeism. So are you missing 14 or more days a year, which is how the national, basically national school associations, what their rate is for absenteeism. So all of these were less likely to report all positive experiences except for mentoring. So again, these positive childhood experiences are having significant relationships with many of these academic outcomes, including absenteeism. Dr. Probst, I believe you're next. Next slide, please. Oh, you're on mute, Jan.
Thank you. How many times do you have somebody, either you're on mute or could you please mute? Okay, excuse me. I want to talk, since we're back into rural, on rural and urban differences in both of these levels of experiences. Next slide. Basically, starting out a little bit, oops, sorry, lost my slide. Take a deep breath. Nationally, since we look at it, 12 million children live in rural areas. For those of you who are active in the field and are treating rural kids, you know all this stuff, so I'm going to just try and go through it anyway. Rural and urban children are equally likely to be insured, but rural children are more likely to be insured by Medicaid, which, as you know, can mean problems in finding a provider. Rural children are more likely to miss at least one day of school. Rural kids, despite this image of, if you ever watched, what is it, that Andy Griffith show when you were a kid, about rural kids running around and playing on the farm, they actually have higher rates of obesity, possibly because of Medicaid coverage, or possibly because of provider availability. Rural kids have lower rates for receipt of preventive medical and oral health services. They're less likely to get the well child visit at the physician or nurse office or at the dentist office. And rural kids have higher mortality rates than other kids. A lot of that is, in fact, unintentional injury due to motor vehicle crashes, but still, it's something that we live in. Rural kids are more likely to die, which is depressing. So rural kids have some disadvantages from the big picture. Let's move on to our next slide. And let's look at the rural kids and the ACEs. Again, there is one of the things that we have found in using this survey and using the youth behavioral risk factor surveillance system is that rural children are not as protected as we think. And if you'll look at these slides, which you may have to do after we're done and sort of squint at them, with the exception of racial ethnic mistreatment, every one of the ACEs is more commonly reported by rural families than by urban families, with particularly sharp differences for economic hardship. For a number of reasons, poverty is more widespread in rural America, and thus logically it affects more rural children, more so than urban children. Substance abuse, we've all heard of the opioid crisis, so that is not surprising that household substance abuse is more common in rural than in urban areas. Also, rural mental illness, neighborhood violence. We think of the cities as being full of trauma. Not just cities. Neighborhood violence is more commonly reported by guardians of rural children, as is household violence. And here is another one that shocked me when we first pulled it up: household incarceration. We know that America does tend to have a carceral society, but 13% of rural children are growing up in a household where at least one adult has been jailed at some point in time or is currently jailed. Holy Pete, as the phrase goes. Parental death is more common, which, given that rural mortality rates among adults are higher, is not surprising. And parental separation and divorce. So this vision of rural as being a bucolic part of America where everything is wonderful and people are skipping about and going to the fishing hole is not precisely accurate, which is things that so there are things we have to do to push positives into rural areas. Next slide, please. As we noted before, those ACEs have a dose response thing. You'll notice that all of the ACEs individually, except one, were more common among rural children. Thus, it is not surprising at all that rural children are more likely to have, somewhere between 1 and 3, and more likely to have 4 or more. 4 or more is the biggie, and we have 7% among rural kids versus 8% versus 4% among urban kids. Again, rural children are more likely to have 4 or more ACEs, with 7% of rural versus 4% of urban kids having that. And correspondingly, rural children are less likely to have 0 ACEs. And, when you looked at this, at the preceding slides, you could tell that this was going to be coming. If you have greater exposure to all of these things individually, you're more likely to have exposure to a big picture. Next slide, please. And this is not gone unnoticed by the big and important people. This is a report issued by the National Advisory Commission on Human Health and Rural Health and Human Services. Dr. Crouch, you contributed to this, is that correct?
Mm-hmm.
By giving testimony to this committee. Basically, they came out with recommendations, which I'm going to read, noting that they are in committees. For those of you who read government stuff a lot, but just the big important words, the first thing that they recommended was that we address ACEs by having a comprehensive prevention strategy. Let me say that again, a comprehensive prevention strategy that identifies, outreach, programming, research. And the other three goals are more along the lines of supporting the first one. The second one is that we should study the economic costs. I'm sorry, I hate that recommendation because I hate the feeling that we have to justify everything that is good by saying it pays for itself. Sorry, that was just an aside. The third recommendation is that we should study, make sure that we include a rural-urban variable so that we can look at the problems that rural children have. And the last one is that we basically improve school-based mental health services, and being a rural committee, they recommended using telehealth. But let's go back at that first one. We need to prevent the long-term adverse effects of these bad experiences. So that's why our current focus on PCEs, prevent positive childhood experiences. Next slide, please. Oops, sorry, as I turn my pages, that must be noisy. Okay, so positive experiences among rural children. Some of those, fortunately, are more common. Next slide, please. There we go. Rural children, this is good. I mean, it's not perfect, but it's at least good. Rural children are more likely to have two specific positive childhood experiences, which is kind of surprising to me because the two that popped up, one was not surprising, one was. Starting with the not surprising one, rural children were more likely to have a mentor outside their home. And for those of us who do a lot of work in rural, the fact that the communities are smaller and you are more likely to know people. I grew up in a small town where it was small. Everybody knew everybody. You could identify the adults outside your community, your own home, who you could talk to. So that does not surprise me. It is, by the way, this was one of the more common positive childhood experiences. And 95% of rural children versus 89% of urban children say they have this. They know somebody outside their home who they can talk to. And that's really important. And on the positive side, South Carolina is pretty close in that. Looking overall at all kids, both rural and urban, 94% of South Carolina kids say there's somebody in their neighborhood whom they can talk to. This one about volunteering surprised me because, again, growing up in a rural community, this is a question asked of children 6 to 17, which means for them to get involved in community school or church, their parents have to drive them somewhere. And again, remembering growing up in a small town and how hard it was to go anywhere because it was so far, I was a little bit surprised that rural kids were actually better. And nationally, 48% of rural kids volunteer in their community school or church versus only 43% of urban kids, which is, and our statistics here in South Carolina are pretty much similar with that. 44% of all kids in South Carolina report that they are engaged in volunteer activity, with that being 55% among white kids and 48% among Black kids. There were not enough data in the survey to give us any further details by race. But so we have some positives in rural that we can build on, which is awesome. I always like focusing on what we can fix rather than what's wrong. Next slide, please. But of course, there's always a but. We also, as you kind of guessed from the fact that I just drilled down from all kids to white kids and Black kids, we all know, and I don't have to tell the people who are in attendance at this conference, that there are many social determinants of health that may influence what is available to kids. Your volunteer opportunities are going to be influenced, for example, by the number of school and community opportunities in your community, which if your community is particularly underserved and impoverished, if your community has, which tend to be characteristics of communities that are disproportionately Black or Indigenous in South Carolina, then you may have fewer opportunities. And we know that rural persons of color from our other research likely to experience worse things. Okay, so we try to tease this out. Like I said, we do want to, one of our features, although we try to be optimistic, we want to focus on what you can fix. But to know what to fix, you have to find it out, which is why we do a lot of work where we tease out not just all rural kids, but rural kids by specific race, ethnicity. And I'm going to pop forward to the next slide, please. And this is just a little bit depressing. This is a national data. Again, there were not enough information and we haven't done a deep breath. There was not enough information for us to tease out all these racial groups within South Carolina, but there is no reason to believe that we differ from everywhere else. And if you look across all of these bars, the first bar is Hispanic, and Hispanic kids tend to have lower levels of a lot of these things in rural areas, which may be a function of where they live. It may be a function of the fact that in many areas of rural America, the Hispanic population is relatively new. This is certainly the case in South Carolina, where we have been a relatively undisturbed, we have Black people and we have white people until the past 20 years, when we have had really an influx of migration into, among other things, rural counties where there are industries that want to employ recent immigrants. The highest bar for all of our good experiences tends to be that second bar, which is for white children who are more likely to report family resilience, supportive neighborhoods, safe neighborhood, after school activities. The one, however, positive that we do have, our next bar is for Black children, Black or African-American children. They tend to top the group, which is interesting, with an adult whom they can share ideas with. Cool, these are strengths we can build on. We want to know, where are the good parts? And as you can see, the good parts vary, but on a positive note, here's the 50% line. It's way down there. Most of these positive experiences are held by more than half of all kids. We have a lot that we can build on to combat the toxic stress and other adverse effects of bad things that happen during kids, if we can figure a way to grow and increase so that all these bars are up at 100. Everybody's got the good stuff. Next slide, please. And with that, I'm going to turn it over to Dr. Crouch, who has been working much more with the local scene in South Carolina than I have, and can finish us out.
Perfect. Thank you so much, Dr. Probst. I did want to give a quick caveat to our previous slides of data that one of the recommendations from the National Advisory Committee on Rural Health and Human Services, Dr. Probst mentioned, was making more rural data available. So what you saw for both the ACE and PCE rural kids, we're limited to about 31 states because we have rural suppression of data. So some of that information about the Midwest or states where we're not surveying any people in population-based surveys will have less kids. So next year, we're invited back again. We were funded by the Federal Office of Rural Health Policy to go into the research data center and start investigating using the full data sets where we don't have the rural suppression, and seeing what's happened in all 50 states versus 31 where it's publicly available. Okay. So the positive, what's happening in South Carolina with positive childhood experiences during the COVID-19 pandemic? And this is, we're going to give what we know about, and then we want to hear back from y'all at the end of this, what you all have seen happening. So next slide, please. So hopefully we have some home visitors on here. We know that we are the evaluators along with the Rural Minority Health Research Center, along with CORE, which is the Applied Research Shop ran by Pam Gillum, who's one of our dear friends. We're both evaluators of the South Carolina Maternal Infant Early Childhood Home Visiting Program. And so home visiting, came in under the Affordable Care Act. It's been going since 2010. It was part of the big uptake with funding getting going in South Carolina about 2013 forward. And so it has been shown to be, there's a lot of evidence-based models that are used by McBee, where we're seeing home visiting, helping parents with modeling of behaviors and parenting interventions and like learning about safe sleep. And there's all kinds of different metrics we collect for this, for our evaluation. So to show how impactful the program is. So starting in mid-March 2020, when the world shut down, home visiting went virtual. At present, home visiting in South Carolina in some places is virtual still, in some places it is hybrid. So we did want to give you all, this is the most recent snapshot of data where we can see what's happened from 2019 to 2020 with some of these measures where we're looking at what's happening within families. Next slide, please. So one of the metrics that we do look at is child maltreatment. And this is a percent of children statewide enrolled in the McBee home visiting program with at least one investigated case of maltreatment following enrollment. I don't know who these people are. Thankfully, it's reported to us in aggregate by DSS through their Office of Revenue and Fiscal Affairs. So for 2020, there were 37.4 investigated cases of maltreatment for 1,000 kids. And this is a decrease from the FY19 rate, and there were of 90.9 cases per 1,000 children. And we do want to hear back from you all at the end, but we suspect that many of this sharp decrease in child maltreatment may be due to fewer reporting. We know that several kids have been lost basically to follow up for home visiting or lost to follow up within school districts. The home visiting and school districts are very strong touch points for kids for child abuse and neglect. And so we're just suspecting that because there's been less in-person interaction, we may have less rates of child maltreatment. National studies have kind of talked about there may be an increase in child abuse and neglect, sadly, during the COVID-19 pandemic, because people are home all the time together and people are obviously under a great deal of stress. Next slide, please. One of the really positive things we measure is parent-child interaction. So they use a validated tool to see what's happening with this caregiver-child interactions. Some of these that are measured are reading to a child every day, singing and telling stories to a child every day, or an additional one that's not through here, but it's measures the National Survey of Children's Health, is eating meals together as a family every day. So these interactive caregiving practices, which we really try to promote in the kids 0 to 5 because it's so crucial for development of language skills. And the language skills have associations and causations with kindergarten readiness, academic achievement, et cetera, going forward. So this is a really great one. So the FY20 percentage was 70.3. It's only slightly lower than FY19. Performance went down, but compared to the child maltreatments, which is way down, the difference is pretty small. I have been just impressed beyond belief with how much home visitors have maximized the use of the virtual setting and kept their clients going, kept interacting with their clients. Our partners at the Children's Trust of South Carolina, which coordinate a lot of the McBee programs, also just amazed by home visitors because they really have helped people try to get internet access or whatever they need in order to make these virtual visits happen. There has been a great positive increase with this. Next slide, please. All right, and then the early language and literacy. So again, that's the reading, telling stories to a child, singing songs. It's a slight improvement from FY19. So 96.6 to 94.2. I know in our own household, we're reading a lot more because we're not going anywhere. So every book in our house has been read in the last 9 months. To entertain during this is a little more challenging for people with small children. Okay, next slide, please. So what can we do to overcome ACEs and promote positive childhood experiences? One thing I didn't actually put in our slides, but I do want to mention is the South Carolina Center for Rural and Primary Health Care has funded our group to coordinate with DMH, the South Carolina DMH, to use school mental health professionals in rural areas to basically give them pay for some of their funding time in order to increase family engagement. And this has been particularly important I never thought when we got this grant back in the spring of 2020, it'd be still trying to figure out, ways to implement within rural in the spring of 2021, and this thing would still be going. But what we've learned from that is school mental health, engaging families in family therapy, and figuring out ways to overcome some of these rural barriers, or transportation to school, transportation to social services. All of that has been it's been a strong learning experience for me, but it's also realized we have a lot of ways that we can overcome ACEs and promote or implement these PCEs. So next slide, please. Okay, so the Center for Disease Control, CDC, has a number of ways. One of the things Dr. Probst mentioned was, among rural kids, economic hardship was much higher, right? We know that rural is often poorer and sicker. And so one of the things we can talk about here is strengthening these household financial security, whether it is increasing the minimum wage, whether it's improving and implementing more family-friendly work policies. I think a lot of these economic supports and childcare responsibilities and all of this has really been laid bare during the COVID-19 pandemic, right? We had not as a society realized how much we appreciated people such as yourselves who are working with early childhood, right? Like how we had not, as a society, given that much thought until we didn't have it anymore because the world had shut down. So the next thing would be promoting social norms. So we have legislative approaches, public education programs. There's a lot of programs. We talked about home visiting, which can help promote social norms. Strong Start, so early childhood programs, preschool enrichment like Head Start. Children's Trust of South Carolina does a lot of work, which I think now is virtual, with some of it's virtual, some of it's still hybrid, with parenting programs. So the Strengthening Families program, if any of you all have been involved with that, that is a great program for bringing families together. In pre-COVID times, they would have dinner together once a week, learn parenting skills, learn these family relationship approaches. Then they would break as parents and kids would have time, parents would have time. And it really created some of these great foundation things that I wish, I'd had my first years of parent or second years of parent. It's helpful to know, right? How do you discipline? How do you redirect? These are wonderful programs for some of that. And then again, it's getting that social emotional learning and these family relationship building. Again, one of the next ones is connecting youth to caring adults and activities. So mentoring programs, after school programs, a lot of things that have been shut down for implementing positive childhood experiences during COVID. But again, I've been very impressed with some of these resilient things I've seen of how home visitors, teachers, educators, et cetera, have been able to connect with their communities regardless of the pandemic. I know it's been tougher, but I've just been amazed what people have done. And then intervention. So primary care, the pediatrician's office, there's a program called SEEK, and it's using SEEK, S-E-E-K. I just wrote down what all it means. I'm used to these acronyms. I don't always remember what the full acronym stands for anymore. But that's using primary care offices such as the pediatrician's office or primary care, often in rural. My uncle is a primary care doctor in rural, and been in the same community for 50 plus years now, and he's seen the kids, he sees the kids all the way into the adults. So you're seeing the full family. So these primary care offices, particularly in rural and urban areas, but particularly in rural areas, can be a great place for intervention where it's not stigmatized. It can be a connection point for social support services. Some programs have been bringing in social workers or therapists within the primary care office, part of the SEEK program. And so you're seeing new ways and innovative ways to reach families. Next slide, please. So parent and home-based intervention. So home visiting programs, I've talked about a good bit. I've mentioned the parent education and support, as well as making resources for parental mental health and substance misuse. So I think one of the things as we've gone through this is, I want to make sure I have time for questions. So I'm going to try to wrap up my section a little bit, but these programs and policies, there's not one approach to implementing, moderating, or preventing ACEs, right? It's a multi-tier, multidisciplinary response, particularly in rural communities. And one of the big things is just education, right? I was very honored to be able to go to Saratoga Springs, New York in 2018 and drive around rural with the people from the Federal Office of Rural Health Policy and the advisory committee. And we had some town halls basically in the basement of churches people in basement churches came and they said, okay, let's talk about what's happening in your community. And some of the therapists that came in, people that worked in schools, the educator, the local principal, the local police chief was there. They had a lot of their stakeholders within their community there. And one of the big things, a lady stood up and said, I now know what ACEs are. I had 7 ACEs as a child, and my child now has 2. We are working to improve the intergenerational transmission of trauma. And so the understanding of what this is and how to reduce it, how to mitigate, how to moderate it, people want to be able to do these things with their children, right? So it's creating these opportunities. So the next slide talks about that SEEK program and gives me my full acronym, which helps me a lot. My memory sometimes, again, safe environment, every kid, again, connecting primary care providers, using them to connect community supports. I think we're most always familiar with family-based resource centers. Again, those may have been impacted during COVID, but are still wonderful. Next slide. Compassionate schools. Before the world shut down, Dr. Melinda Mayer was at our research center and I drove to Spartanburg for 2 days. And we hung out and went to a compassionate schools training at University of South Carolina, Spartanburg. It was really impactful. So the PI for this grant there is educating educators. So we have elementary school through high school, as well as she was doing medical students and teaching them how to recognize and help deal with traumatic experiences. And so it was one of the most wonderful 2 days I've spent learning about this as a researcher, because they had they had gotten funding to do a model house. So you could go through and see what kids might experience at the house. Then they had a thing about, okay, if kids can't pay attention at school, what is ADHD? How does that relate to toxic stress? How does it relate to trauma? So it was really getting into how we best help people learn to, for especially children, self-regulate as a result of trauma. And some of these things as an adult, I wish I'd known when I was a kid. It was really so helpful. So that's Compassionate Schools. Next slide, please. Children's Trust of South Carolina. I cannot say enough wonderful things about all the work they do. One of the big things they've done is this a lot of training on what is ACEs, so what are these adverse experiences, what's your score, and then the next slide would be they're learning at, next slide please, they're training the trainer. So Dr. Beth Radcliffe, who was a dear friend of mine who worked with us at the Research Center for many years, she was a train the trainer, and she would go around training people about ACEs. So she would go in the community, she went to churches, she went to schools. She spent a year in Africa last year, pre-COVID, but she had to leave early because of COVID, but again, training there about ACEs and helping with early childhood. And it's just really helpful because, again, as I gave the example from the New York conference we went to, and we drove around rural New York, people want to know, because people want to be able to move forward and help their own children and their own families with this, right? And so one of the ways we do this is through education. So next slide, please. All right, statewide resources. I talked a lot about home visiting and advocacy groups, as well as South Carolina DMH, which has been very helpful with our group. And then we've got some links on the next slide, please, because I want to allow time for some questions. National resources. And then finally, next slide. Connecting the dots. So I hope today's meeting was really impactful for you. I know I learned something different every time I talk and give one of these. Attending meetings, networking within the state to kind of bridge some of these different organizations, and we know what all we're doing. We can do it better if we know how to connect families to multiple trainings, programs, and agencies. Again, Compassionate Schools, other programs where we train healthcare providers to learn about ACEs and learn about trauma and how we help children learn to social emotional regulation. And then hopefully we've made you all more interested in rural now, and we are inviting to early childhood professionals to rural health gatherings now. Yes, and I see the chat about the Saratoga Springs. We're in Saratoga Springs for just some morning meetings, and then the next 3 days we drove an hour and a half, 2 hours out into rural communities. That's a great point. It is buzzing compared to the areas around there. Yes. All right. Can we get the next slide? And then one more slide, please. All right, so we want to hear back from y'all. I know we've missed what's in the chat box during this, but adapting to these COVID-19 challenges, we've talked about what we know we have home visitors done, but What about some human interest stories? How has COVID-19 affected your all's work as early childhood educators, and what questions do you all have for us? So I'm going to open the moderator to say we're happy to take questions about some of this work. And thank you all very much for having us.
Wonderful. And folks should continue including some questions in the chat. And if we run out of time to get through those, I'll be sure to share those with our speakers, and we can try to get some responses that way as well. So I would say in general, a lot of the comments that came in during the session were about sort of, I didn't know this before, which is always a really rewarding sentiment to hear during a presentation. One person said this presentation is so timely and relevant to current policy efforts. We need to focus more on the needs of the rural child population. Somebody else pointed out that after seeing some of the graphs in particular, it expounds on their belief that on the things that matter, we are not as different as people like to think, and that's a positive in my book. And so clearly, you know, our attendees have sort of been processing that some of the similarities that we see are, you know, deeper than we thought, and some of the differences are surprising, you know. So one question I think coming out of that is, what do we do with this newfound knowledge? How do we go out and evangelize about the needs of rural students, rural children, when so much of the policy conversation tends to center on urban areas for reasons that aren't the fault necessarily of the kids who live there? But how do we make sure that those rural needs, you know, that we're not just seeing it as sweet little rural communities, but really make sure to ground both the needs and the positives of those communities in our work?
Dr. Probst, I'm going to let you hit this first because Dr. Probst is nationally known rural. Go ahead.
I'm going to say there are so many things you can do. South Carolina has such a history of, if you want to remember the Carter shame and the lawsuit with regard to equitable funding for schools in rural areas that went on for 20 years, South Carolina has a long tradition of somehow managing to ignore really very important rural issues. Schools are overwhelmingly important for kids. I mean, that's where they get the start that they're going to get on their future. I would say being attentive, unfortunately, I have to say, we're going to have to think about what our elected officials will do for us and vote for the ones whom we believe will best give us the vision that will help move our kids forward. We do need more funding for schools, both for the basics and for things that people tend to think are not important, but things like the art programs after school, things that people think are frivolous are, as Dr. Crouch was just pointing out, these are important. These are the positive experiences that can help overcome some of those negative rural experiences. This can be down to the level of, if you're a dad, I remember a rural dad complaining about the fact that there was a baseball field, but they couldn't get enough volunteers to mow it so that the kids could play there. Oh my word, having the kids playing sports is important for avoiding so many problems. It's not the sport particularly, it's the fact that they're together, they're learning interactive skills, they aren't off, you know, smoking behind the grandstand or something like that. So being supportive as a volunteer in your community, being attentive to what is going on. I would also say being attentive to the degree that you can support policies that help us get healthcare into rural areas, because some of these things can be picked up and people can be can receive referrals through their primary care provider's office, whether it's an advanced practice nurse or a physician. But to do that, we have to have adequate funding. And the reason I'm gonna toss out a potentially controversial thing, this is the reason we need to expand Medicaid. One of the things that research has found is that when the parents are insured and are getting instructions from their own personal healthcare provider, that trickles down to the kids. They are more likely to take the kids in for preventive services because the physician or other primary care provider is educating the parent about these things, and it's the parents who do things for their kids. There is a lot of interconnectedness. Jobs, support for any kind of jobs program in rural, because as we have people with more and better incomes, there's a wonderful study that I won't give you the cite for because I don't want to drive you crazy, showing that one of the things that happens when parents get out of poverty is that they have more attention to focus on their kids because they aren't working so hard to keep, you know, food on the table, and they can have a little bit more time to read and do all those things. So there's a variety of activities. I would say be attentive, get involved. work with your schools and with your local, like say healthcare facilities. Work as a volunteer at the local library. Libraries are awesome resources for kids and for services. And now I'm going to stop because I can go on forever.
Well, and we are right at, we're at 12:01 actually. And so I'm going to archive the questions that are in the chat that we didn't get around to, and then I can share those with you offline. We will be sharing a follow-up email after the event with the recordings and some PDFs of slide decks as well, so we can share other resources as well. I just want to, again, thank our presenters. Thank you, Dr. Crouch. Thank you, Dr. Probst, for these insights, which, you know, as a moderator, I love when I don't just get to work a session, but I get to learn from a session. And I think many of us really, you know, challenged and deepened our knowledge today. So thank you for your time. Thank you, everybody, for participating. And hopefully we'll see you all in your next breakout sessions, which begin at 12:30 after a brief break. Thanks so much.
Thank you.
Thank you.